Hi everybody, this is Renee, and in this voiceover we're going to talk about pediatric skeletal disorders. So the key difference between a child's bone and an adult bone is the presence of physis. Physeal injuries are very common in children and make up approximately 15 to 30% of all bone injuries. The growth plate, or physis, is a translucent cartilaginous disc, and it separates the epiphysis from the metaphysis, and it's responsible for longitudinal growth of the long bones. The cells of the physis are arranged in columns or layers described as the resting layer, proliferative zone, hypertrophic zone, and then the zone of provisional calcification. So the proliferative zone is where the chondrocytes undergo division by mitosis, and it is the most metabolically active zone. Osteoblasts use these columns as scaffolding for ossification. In the zone of provisional calcification, the hypertrophic zone is the weakest, and that's because it lacks the collagen and calcified tissue. Most physeal separations occur through this layer, and that's because it's less able to resist shear and stress. So fracture classification. So just to review the different classifications of general fractures, the first is the green stick buckle, where only part of the bone fractures and the other part does not. And remember, this is very common in young children. A simple fracture where the break goes through the whole bone without damage to surrounding tissue or breakage to the skin. A comminuted fracture is a break or splintering of the bone into two or more fragments. And a complex fracture usually has injury to multiple bones, joints, ligaments, and tendons. And this typically requires a more invasive treatment and rehabilitation. Physeal fractures are those fractures that happen around or through the growth plate, and these are classified using the Salter-Harris classification system, and they go from a type 1 to a type 5. So with a physeal fracture type 1, this is a transverse fracture through the growth plate, and in type 1, the epiphysis is separated from the metaphysis. The plane of separation is horizontal, as you can see on the image. Displacement is usually easily reduced, and treatment includes casting. Healing is rapid for type 1 fractures, typically within 2 to 3 weeks of injury. So the type 2 physeal fracture is the most common type, and this accounts for approximately 75% of all physeal injuries. As you can see, there's a transverse fracture through the growth plate and an oblique or vertical fracture through the metaphysis. The type 2 injury starts as a horizontal separation, kind of like in type 1, but this is completed by exiting through the metaphysis, resulting in a triangular fragment which varies in size. This is also usually easily reduced, but not always easy to hold the reduction in a cast. Sometimes the torn periosteum becomes trapped in the fracture site, and this will prevent a full reduction by closed means or casting. The trapped periosteum sometimes needs to be released by open reduction, especially in the ankle. On to the type 3 physeal fracture, and this is a transverse fracture through the growth plate and a vertical fracture through the epiphysis. While this is not a common fracture, it is more commonly seen with older children where the growth plates have started to close. It's a combination of a horizontal fracture through the physis and a vertical fracture line which runs through the growth plate, through the epiphysis, to the articular surface. Displaced injuries may result in a physeal bar, leading to growth disturbances and arthritis. Most displaced type 3 injuries require open reduction and internal fixation, also known as ORIF. Type 4 physeal fracture is a vertical fracture through all three components, so the metaphysis, the epiphysis, and the physis. In a type 4 separation, the fracture line is vertical. The most common example of a type 4 physeal injury is the separation of the lateral condyle from the distal humerus. The injured tissue must be accurately reduced and lined up with each other to minimize the risk of a physeal bar. Most displaced type 4 injuries require ORIF and long-term follow-up to detect growth disturbances. So the final fracture is the type 5 physeal fracture, and this injury is very rare. It's also hard to see on an x-ray. It's a compression fracture or crushing of the growth plate, and these injuries are almost always diagnosed retrospectively when growth arrest has occurred. All right, so moving on to toddler fractures. A toddler fracture is often a spiral or oblique undisplaced fracture of the distal shaft of the tibia, and then the fibula is still intact. This occurs in children less than 2 years of age typically, and there usually is not any severe or noticeable injury, and it's when the children are learning to walk or run. What happens is the child will refuse to bear weight on one leg, but all injuries should be ruled out, including child abuse, especially since this is typically a spiral fracture. Treatment for a toddler fracture usually includes an above-the-knee or long cast for about 3 to 4 weeks. Moving on to femur fractures, these are the most common fractures for long bones in the pediatric population, and it is more common in the summer months because this is when children are more active, and they're typically going to happen from traumas such as falls or sporting accidents, and they can also happen from car accidents. If there is a femur fracture in a toddler, child abuse must be ruled out. Treatment options for a femur fracture include traction, a Spica cast, which we're going to review on the next slide, ORIF, and external fixation, so pinning.
Femur fractures are the most common fracture for long bones in the pediatric population. And it's more common in the summer months when children are more active, and they typically happen from traumas such as falls, sporting accidents, or car accidents. If there's a femur fracture in a toddler, child abuse must be ruled out. In fact, all of the femur fractures that I've seen in my years of practice for toddlers have been because of child abuse. Treatment options for a femur fracture include traction, a Spica cast, which we'll go over in the next slide, ORIF, and external fixation, so pinning.
Now we're going to talk about the Spica cast. So a child who is in a Spica cast will require regular assessment of circulation, including sensation and movement of the lower extremities. A hip Spica cast is an orthopedic cast that is used to immobilize the hip or the thigh. It is used to facilitate healing of the hip joint or the fractured femur. A Spica cast includes the trunk of the body and one or more of the legs. Because the Spica cast actually covers like the entire lower half of the child's body with only a small peritoneum opening, management of the child's elimination can be challenging. There are precautionary measures for the child's caregiver that should be taught. And the first is that tucking of the disposable diaper underneath the cast edges of the peritoneum opening, and this is going to help prevent the cast from becoming soiled. Plastic sheets should be avoided, and the head of the bed needs to be elevated during elimination. And this is going to assist with feces and urine running down and away from the cast. Any signs of infection, including fever, wound drainage, and extreme pain, should be reported to the healthcare provider immediately. The child should be moved and turned in position every 2 hours during the day, and items should be within their reach. Extremities can be supported with pillows, rolled up towels, and a beanbag chair. The child's diet should also be high in protein, fluid, fiber, calories, and calcium. This will help prevent any constipation, and the child should remain in an upright position after feedings for approximately 30 minutes. So, hip dysplasia can be either congenital or developmental. It can happen in utero positioning, especially if they're breech. It can also happen during birth if they have a petite mother, and there are higher incidences if they are born in water. Because of the cause of hip dysplasia can be from a multiple number of factors, it can often go undiagnosed until 6 weeks of age, where they will confirm the diagnosis with an X-ray. It is more common in females, and certain neurological conditions will increase these risk factors for developing hip dysplasia, such as CP or other spastic neuro conditions. Treatment of hip dysplasia includes the Pavlik harness, which you can see in the picture on the top of the slide. If the harness is used, it is important for the nurse to assess the neurovascular status and to also provide proper education to the caretakers. Bryant's traction is also an option for the treatment of hip dysplasia, and that is the picture on the bottom of the slide. The Spica cast and surgery are also treatment options. If hip dysplasia is left untreated, the pain will be present due to the arthritis that's going to develop within the joint.